Hello and welcome to the diabetes lecture. Going to talk about all different aspects of diabetes management from a medication perspective. But really what it comes down to is manipulating the way that our body uses sugar, uptakes sugar, releases stored sugar, and stores sugar. So there's a lot of different ways we can manipulate the different processes in the body, and we'll talk about those. But basically, diabetes involves as a disease, involves some sort of an issue with either intaking too much sugar and not being able to use enough of it, not having the correct pathways to store sugar, or possibly in the case of like in type 1 diabetes, for example, where you'd have a actual autoimmune disease where your pancreas can't produce insulin. So you get lots of different shades of problems within diabetic patients, and sometimes it's as simple as a dietary change. Other times it might be so far gone where they actually have significant insulin resistance throughout their whole body. So you have to think of different, more creative ways to treat diabetes. Just the glucose metabolism, I don't think I need to go through that. Diabetes is sort of like hypertension, where it's also, I think of it kind of as a silent killer. It's going to be something that's not going to be that impactful immediately, but over time, it'll certainly cause damage, especially to microvasculature. And things like eye problems, neuropathies are kind of what people think about with diabetes, but remember, it also increases your risk for kidney disease, heart disease, peripheral vascular disease, and increases your stroke risk. So chances of TIAs, CVAs, and dementia all go up substantially with diabetes. I like to think about it as you have these little tiny glucose molecules that go through your bloodstream, and normally that's fine. You need some glucose because it's an energy source, especially for your brain and your muscles and pretty much everything else in your body. So it's very important to have glucose circulating and readily available. But if you have too much, that's too much of those little molecules getting pushed through small vascular spaces, and over time that causes damage. And if you couple that with high blood pressure, then you've got a double-edged sword there, where the blood pressure itself is pushing harder, and you're pushing these small molecules in larger quantities through small vessels, small blood vessels, and that can cause damage over time. We're going to start with type 1 diabetes, or diabetes mellitus type 1, DM1. This is one of the most common chronic diseases affecting children. So if you go into pediatrics, you'll probably see this a fair amount, especially if you do like pediatric internal medicine. It is an autoimmune disease, so your insulin-producing beta cells in the pancreas are destroyed by your immune system. And there's a lot of different components to this, but we don't really know exactly what causes it. The reason why it's delayed, why we can't really diagnose this at birth, or at least not very well anyway, is there's I don't know, maybe I'm misspeaking there. Maybe there's some genetic testing they can do now. I don't know, probably. At least maybe that'll be something soon. But the point is that you don't see symptoms of type 1 diabetes until later in life, because your pancreas has a lot of beta cells to begin with. It takes your body a long time to get rid of those to the point where you get significant side effects and symptoms to be seen. This is also known as insulin-dependent diabetes. Oral medications are not useful for type 1 diabetes. So that's a big difference right off the bat. Type 1 diabetes is going to be always insulin-based regimens. And while we can use insulin-based regimens for type 2 diabetes, we're going to stick to insulin only for type 1. And for type 2, usually we start with oral before we go to insulin, depending on how severe it is. Epidemiology, I always like looking at this kind of stuff, just looking at the rates of type 1 diabetes incidence worldwide. And I just think it's sort of interesting that Northern Europe and the US, Australia obviously has British settlement. So you've got people of Northern European descent that seem to have a higher propensity to get it. So why is that? We don't really know. Interesting observation, though. As far as and geographical trends, again, I'm not going to talk about that anymore. I just think it's kind of interesting. If you look at age and gender, there's two different onset types. There's usually a 4 to 6 years and about 10 to 14 years, but about 45% of patients will present in that earlier onset. So it's about split between when patients are going to present, if they're going to present sort of in early childhood or more closer to adolescence. There's no gender difference, although females in general tend to have higher incidence of autoimmune diseases. Like if you look at Crohn's disease and psoriatic arthritis and rheumatoid arthritis, females tend to be more prone to those diseases. But with type 1 diabetes, there's not really a trend there. Incidence seems to be rising, at least maybe we're documenting it better. I'm not sure. Maybe worldwide you're seeing more cases being actually reported correctly. So I don't know. It's always hard when you get more activity as far as public health campaigns and things like that go to actually identify certain diseases versus as they're actually an increasing prevalence. It's kind of hard to tell that because we don't know exactly what they tracked 100 years ago versus today. Genetic susceptibility, again, just something kind of interesting to see. There is likely a genetic component, although it's fairly small, unless you see like even offspring with both parents affected, up to 30% of people get it. So and then twins are really interesting too because it's not a guarantee, which is kind of strange. So there's some genetic component there, but seems to be something else going on as well. Classic symptoms. So diabetes is going to be characterized by an increase in blood sugar. So if you think about that from a pathophysiologic perspective, what does it do when you have a bunch of extra solute in your blood? Well, first of all, polyuria, you're going to produce more urine, and that's the body's mechanism to get rid of the extra solute, in this case, sugar. So your blood sugar goes above 180 milligrams per deciliter, you're going to start to increase urine production. The body wants to excrete this, so it increases urination. For older kids, they'll probably just complain that they're peeing more. For younger kids, especially in like the 4 to 6 year old group, I mean, I'm not judging, but hopefully your kid's potty trained at that age. But if they aren't, that might be hard to tell. But if they are potty trained, or like, if your kid's been sleeping through the night without any accidents relatively well, then all of a sudden they start wetting the bed. That could be a sign that they might be developing some of these symptoms. So that's a way we can check with the younger crowd. Polydipsia is increased thirst. That's just because you have increased serum osmolality. It's your body's mechanism of telling you need to dilute that out. Weight loss, so hypovolemia, increased catabolism, impaired glucose utilization can cause fat and muscle breakdown, and also patients with high blood sugar can express nausea and anorexia in severe cases. So again, insulin therapy is required for all type 1 diabetes patients, and therapy will start at the diagnosis of the disease. So as soon as they're diagnosed, you're going to start them on some kind of an insulin regimen. The goal of therapy is to prevent any long-term complications, as we mentioned earlier. And there's a lot of products available, including continuous insulin pumps, which are an option for some patients. So as far as treatment consideration go, there's two different schools of thought, and conventional treatment is probably what you could think of as maybe like the old school way of doing things. It's not really a respected strategy anymore. So I wouldn't ever recommend this unless you had a patient who's really non-compliant and really struggling with cost. Maybe you might be able to just get them by on that, and that it's better than nothing type of a strategy, but you really want to avoid this if you can. Conventional dosing was the original way they did insulin therapy, and it was usually single or twice daily injections. And the problem is that we have products that last a long time. We don't have products, or what I should rephrase is that's not how the body produces insulin. So when you look at an intensive regimen, what that is multiple injections per day designed to mimic physiologic insulin. The core concept behind an intensive insulin regimen is to have a basal insulin that's always available. So you're giving something that is immediately available in case you have a spike in blood sugar or something like that. And that's how your body works. You always have some insulin available to be used at any given time, assuming your pancreas is functioning. And then with meals, you can inject an extra amount of short acting or with snacks. So you might be doing a minimum with an intensive is 4 injections a day. So that's 1 basal injection and 3 with meals. But your basal injection could be twice a day. Your meal times, you might have a snack in there sometime when you add it. You might do some at bedtime too. So it could be 6-7 times a day as well. So it's a lot of injections. And you get to the point where you're thinking like, gosh, I'm injecting myself 7 times a day. Maybe I should just get a pump. And that's where pumps come in handy because it even better mimics the overall approach of endogenous insulin released by the pancreas. So we'll talk about pumps in a second. But let's talk about insulins for now. 2 ways of giving insulin. The old way of giving insulin is the vials that you actually take in a syringe with a needle on and draw up that way. These still exist, so it's not like they don't make these anymore. And they're cheap, so people with significant cost issues might be able to afford this a little bit better, but it's not going to be as convenient. And overall, the standard of care for insulin delivery is going to be the pen system. Pens are kind of what they sound like. They look like a thick pen. And they have if you take off the cap of them, you can see there's this barrel here. And with that barrel, there's gradients on it. So you can see how much liquid insulin is left in the pen. And then you have these little pen needles that you screw onto the end. They're single use. And the pens are cool. You can see this. Hopefully you guys can zoom in a little bit on the PowerPoint if you can't see this very well. But you can look at the window here, and you can see that there's a dial that this person is touching right here, and there's a window that tells you how many units you're drawing up. So if your dose is 10 units of levemir twice a day, you dial that up to 10 and do your injection in the morning and the evening. It's great because it takes a lot of the guesswork out. You don't have to worry about, oh man, did I draw that up too far? Did I accidentally get it on the wrong gradient? We're talking about small amounts of insulin. It can be difficult to draw that up because it's such a small volume, which is nice because when you're injecting something, you don't want a huge volume of liquid, especially subcutaneously. But it can be tricky to do this with this method. However, with a pen, it takes a lot. Again, it takes that guesswork out, so it's a little bit easier. Granted, pens are much more expensive for patients to pay for, but there's certainly insurance will generally cover that. Again, it's sort of the standard of care, so most insurances should pay for the pen treatment. As far as basal options, so these are what's known as basal or long-acting insulin. There's a couple on the market. The one that's probably the most popular is going to be glargine-related products. Lantus is the brand name of that. And glargine products have been kind of the standard for basal insulin for quite a few years now. There's a couple other options too. There's Detamir, which is Levemir. The tricky part about that one is you have to dose it twice a day. And there's the newest one, which is Degludec, which actually lasts longer than glargine. So that one's getting some popularity just because some people will argue glargine, while it should last one injection a whole day, you do get some dips in there, whereas Degludec, has like a 36-hour half-life or duration of action. There's intermediate acting insulins, NPH, regular insulin. These don't have as significant of a role because they really don't mimic how physiologic insulin is used. There's rapid insulin, which are usually what's known as mealtime insulin. There's 3 different ones of that. And then concentration is really important with insulin. So generally speaking, all insulin is going to come as 100 units per mil, but this is starting to vary. As people require higher and higher doses of insulin, that volume of liquid gets difficult to absorb and inject subcutaneously. So there's some products out there that are now 200 units per mil or 300 units per mil, or there's even a really high concentrated version of regular insulin called U500 that's 500 units per mil. And we'll talk about that all again here in a second. As far as how things absorb, if you have endogenous insulin, so your pancreas releases insulin, it's going to go right in the bloodstream. It's basically instantly bioavailable. There's no subcutaneous absorption period, which is this delay that we're seeing here with these different insulins. So even a rapid acting still takes about half an hour to an hour to really kick in. I mean, within a half an hour, you see some significant amount of absorption. Within an hour, you're probably close to your peak, and then it sort of just tapers off really fast. So again, it's designed to mimic that spike your body would give you for a mealtime insulin. If you look at something really long acting like glargine, it's got a very long onset, but then it doesn't really have any type of a peak. It just sort of gives you this standard steady state, which is really nice for mimicking basal insulin. Or endogenous basal insulin. And then if you gave another dose, the next day, you shouldn't really have much of a dip. But again, some people will struggle with that a little bit. These are just the insulins compared on a chart in case you're curious about the different onsets and things like that. One thing I don't have on here, I don't have the new one, which is Degludec, and we'll talk about that in a minute here. So your basal insulin, again, glargine is probably the preferred one. It's the one that, again, has been around a while, and most insurances will direct you towards this. There is a couple different brand names. Lantus and Basaglar are the 2 that are basically interchangeable, and Toujeo is the new one, which is a highly concentrated glargine product, which is U300. So that means it's 300 units per mil. So for patients who require large basal insulin doses, These are mostly going to be your type 2 patients who are highly insulin resistant, not necessarily a type 1 patient, although it might be something you see. But when you see these huge doses of basal insulin, that might be a time to switch somebody to a U300. Duration's about 24 hours, but some patients report variable data, and there's a debate out there about whether you should really give this once a day or if it's better twice daily. So don't be surprised if you see Lantus or Glargine products dosed BID or QD. Degludec comes as a U100 and a U200 product. Traceba is the brand name of this one. And it's got a 25-hour half-life, so it's a little bit longer, 3 to 4 days to hit steady state, but it's been approved. So I think I said 36 hours. I think that's what I meant by that was that's sort of its total duration of action. I think I might have said half-life, and sorry if I misspoke there. But its half-life's 25 hours. It hits a steady state, and then it should have a nice gradual level of insulin that doesn't really spike at all. Compared to Glargine, theoretically, there's lower nocturnal hypoglycemia reported. The problem with Glargine that people run into is a lot of people inject it at bedtime or around the evening time. And so you do get a little bit of a peak with Glargine. Even though it doesn't have much of a peak, it will have a little bit of one. And so people will argue that patients get hypoglycemic in the evening because their Glargine is a little bit more potent during the evening, during those overnight hours when it's initially highly concentrated and absorbing faster than throughout the next day. So some patients, if they're monitoring their blood sugar overnight, like with a pump or something like that, or with maybe a continuous meter, I don't know if you guys have seen these things, but they can communicate with your phone via Bluetooth. It's pretty cool technology. So they might pick that up, and so or a patient might wake themselves up in the middle of the night. Maybe they wake up trembling or feeling really tachycardic or something like that. That's a core hypoglycemic symptom, and so they check their blood sugar and they're in the 40s or something like that. So that's come up with Glargine occasionally. It's not something that affects all patients, but affects some. In those patients, Degludec might be a better option because it doesn't seem to have that same if you take it in the evening as your dose, you don't really get that low blood sugar that can occur with Glargine patients. Detamir is a lot more variable, and it's not as consistent of a low steady level as Glargine or Degludec, so it's generally not recommended, but it is something that's used occasionally. Detamir I've never seen Detamir dosed once daily. It's always dosed twice a day because of the duration. It just doesn't last a whole day. So you get too many peaks and valleys in your blood concentration of insulin if you just used a Detamir product once daily. So that's not going to be as convenient if you're trying to minimize injections versus Glargine and Degludec. You can usually get away with one injection a day. Mealtime insulin, glucine, aspart, and Lispro are all essentially the same. It's easy to remember. Think of all three of these as mealtime short-acting insulin. You're probably going to be directed towards one based on what your patient's insurance plan pays for, and it'll be the mealtime insulin of choice. Humalog comes as a brand name that is Humalog. Humalog is Lispro. Lispro comes as a U200 as well, so there is a more concentrated formulation out there. Onset's about 0.2 to 0.3 hours. Peak is 1 to 3 hours, and duration is 3 to 5 hours. So short acting, doesn't last a long time. If you overdo your mealtime a little bit, the nice thing is it should be out of your system relatively quickly. Other options for insulin, there's NPH, which is, I always forget this name, protamine hagoderm or something like that. It's got an acronym that some guy made a molecule that went on the end of insulin to make it last a little longer. There's also regular insulin, which is 3 to 4 times daily. That comes again as a U500 product. So some patients you'll see who have really high insulin requirements, they use that U500. Insulin is regular insulin itself is relatively cheap, so that's where you might be like, what is the advantage of even giving somebody a 3 to 4 times a day regular insulin when you have these other strategies that are better? And it's just because of cost. Some patients might not be able to afford insulin, the traditional preferred methods, so regular insulin becomes an option for them. Mixed combinations, there are some short-acting, long-acting, middle-acting combos out here. These get really complicated. I'm not going to test you on them because they're a little bit convoluted as far as how you use them. They are used occasionally, but not as popular as the just standard regimens, I would say. So if you're designing an initial insulin regimen for a type 1 patient, what you're going to look at is calculating a total daily insulin dose. And I don't want you to have to memorize this. I'm just giving you this as an example for how you would approach an insulin patient. You would initially do about 0.2 to 0.4 units per kilo per day. But the patient might end up needing about 0.6 to 0.7 units per kilo per day. Especially teenage patients who maybe have higher metabolic demands might require even more than that. You can adjust the dose daily, so depending on the symptoms and blood sugar measurements. So when you're titrating somebody up, you can check in with them regularly to adjust their dose. 1/2 of the dose should be given as basal insulin, so half of this total daily would be your basal. And then if you were giving a BID version, then you would split that further in half, of course. And then the remainder would be given as your short, rapid acting before meals. So an example of mealtime insulin, there's a couple ways you can do it. The preferred way is to do a sliding scale plus a carb counting method, which is right here. So that means that you give a certain number of insulin per unit of carbohydrate. So it might be like, I can't remember what a unit of carbohydrate is. I think it's usually like 15 grams of carbs is 1 unit. Sorry if I'm offending any dietitians in the group. I'm forgetting right off the top of my head. But anyway, there's a fixed amount of grams of carbohydrate. But by the way, that's a good plug that dietitians should be heavily involved with diabetic patients, or at least an initial consultation so they understand this. And some patients, honestly, might not be equipped to do carb counting. They just might not get it. It might be too confusing for them. So in that case, you might just do a fixed dose with each meal and hope it works out. But the ideal is to carb count. So you do 3 units per carb choice or something like that. It's just kind of a random number I threw out there, but it's a common method. So based on how many units of carbohydrates, that's how many units of insulin you would give. And that's with each meal. So if you eat a meal that's lower in carbohydrates, you should be not using quite as much insulin. If your meal is really high in carbs, you'd use more. So that makes sense based on how much you're intaking versus a fixed dose where it's like, well, what if I ate, basically just a bunch of vegetables or something for lunch? Well, that's not as high in carbohydrates. And so I shouldn't just be using the same amount as if I ate pizza for dinner. So those things are important. And of course, if you can manage that with carb counting, that's going to be a much more accurate way to do things. And then you have a sliding scale. So the sliding scale is designed to pick up the slack in the system. So let's say you go into your meal and you're about to eat dinner, you take your blood sugar, and it comes back as 170. Well, that's a little higher than you want it to be. So that means you have some residual blood sugar left over from your last meal, or your insulin didn't quite pick it all up. So let's do a little bit more than we'd normally do. So what that means is that you're going to carb count for that meal you're planning on eating. Plus, you're going to add that 1 unit on because that's what your sliding scale is. Now, this is sort of a standard sliding scale. Sliding scales can be much different than this depending on the patient. You really have to work with the patient and figure out what the best one is for them. But a basic idea is just to slowly increment the number of units of insulin you're giving with each meal based on how much blood sugar they have before they eat. So again, you're trying to compensate for the fact that they're eating a meal, but their blood sugar is already elevated. So we carb count for that meal, but we also want to add a little bit more insulin on top of that to make sure. And again, this can be very heavily fixed on or heavily dependent on the patient's ability to maintain these. It's not easy to do. You have to figure out the sliding scale. You have to figure out the carb counting. There's a lot of things involved with doing insulin. And eventually, it probably becomes second nature, but it could be a little bit jarring for somebody to start with, especially a kid, and having their parents have to manage all that can be challenging. Blood sugar monitoring is, of course, critical. So there's a lot of different products out there to do this. They all basically do the exact same thing. They're relatively inexpensive, and in fact, a lot of the monitoring actual devices are free. The companies, it's kind of like razors, right? The razors are cheap, the handle is cheap, but the company makes money off the blade replacement. In this case, they make their money off strips. So the strip replacements are where they make the majority of their things. So they'll say, yeah, we'll give you the free thing, and then you're going to be a strip customer for life. Great. Basically, any type of blood monitoring system is acceptable, and it's essential for any type 1 or type 2 diabetic patient. Most people are going to test 4 to 7 times daily, usually AM, PM, meal times if they exercise, those types of things. Single blood sugars are really not super helpful, but trends are really important. So being able to look at somebody's meter when they're in clinic and say, okay, here's where your blood sugars are going, you can really see their trend. Usually meters will have, a month or 2 months or maybe even more data that you can pull by looking at their history there. Hemoglobin A1C is, of course, really important for diagnostic criteria. This is not something we use for type 1. We don't really care about their A1C. That's a type 2 thing. We'll talk about that in a little bit. But that's just showing you essentially a long-term snapshot of their blood glucose over the past 2 to 3 months. So with a type 1 patient, we're more concerned about, are they getting hypoglycemic? That's probably the biggest question you want to ask your patients about symptoms is hypoglycemia, because if anything with insulin's a really high risk medication. If you look at the grand scheme of things, you're giving a medication that lowers blood sugar, and if you overdo it or do it incorrectly, you can have significant consequences to that. All right, continuous infusions. Short-acting, rapid-acting products are used as in an infusion pump in an effort to mimic purely endogenous insulin. So you don't have any basal insulin that you're injecting. The insulin pump will continuously infuse aspart or Lispro or glucine into your subcutaneous port thing. I don't know if this could be called a port, probably not. But you have this little infusion set or whatever this is called that pokes in subcutaneously. You have it hooked up to the pump. The pump feeds it insulin in constantly, and you can bolus yourself at meals depending on. So if you're carb counting with your meals, you can add a bolus on top of that and do your mealtime bolus. Pumps are cool technology, and even cooler technology now are the sensors out there that are designed to communicate with the pump. So a sensor, well, I should back up a step. That's sort of futuristic at this point. But you also have sensors that you can put on your arm that communicate with your phone or with your blood glucose monitoring device that can tell you when your blood sugar gets low. So if that alerts you, you can take action with your pump immediately. Now, there is some technology out there where the insulin sensor, the blood glucose sensor can communicate directly with the pump. So it can say, hey, your blood sugar is getting low, talk to the pump cuts itself off or decreases its rate or something like that. A lot of those strategies are in FDA approval processes right now, whereas I've actually read stories, interestingly, that people will buy older pumps and they can hack the radio frequencies of them, so they can actually link up and create sort of a system like this. Whereas an interesting example of people have developing technology ahead of where companies, obviously a company like Medtronic or something that makes insulin pumps has thought of this. Not like they haven't, but going through clinical trials and FDA approval process can be rigorous. So whereas somebody in their garage can hack an old pump with a radio frequency change and allow it to communicate directly with your sensor, that's pretty cool. So I hope we get to the point where you almost have this artificial pancreas system, like how this is designed. So you've got your sensor checking your blood sugar. It communicates directly with the pump. The pump will adjust insulin accordingly. It's a closed loop system. So again, not an artificial pancreas per se, but sort of an external artificial pancreas functioning that way. Okay, hypoglycemia, again, this is the biggest risk with insulin. Insulin doesn't really have any side effects to speak of. You might get some injection site irritation or maybe an allergic response to certain types, but otherwise, overdoing it's your biggest concern. This is going to happen usually when blood sugar dips below 70. Kind of the key things are shakiness, tachycardia, sweating, feeling dizzy, anxious, being really hungry, fatigue, irritable, those types of things. I think about being hangry, but on steroids. Insulin, again, has the highest risk of any anti-diabetic medication. It's profoundly affecting your blood sugar, and so anything that affects that's insulin is going to drop your blood sugar and is going to cause a possible hypoglycemic event. So diabetic patients who are on insulin or other medications prone to hypoglycemia need to have some sort of simple sugar available at any hand. So we have things like glucose tablets or glucose gel that absorb really quickly that can get blood sugar back up very quickly, even when given orally. In severe cases, hypoglycemia can cause coma, seizures, and death. And in those cases where people are severely hypoglycemic, we're going to look at IV dextrose. Another rescue option is glucagon. Glucagon is a peptide hormone produced by pancreatic alpha cells, and you can give a synthetic version of it in emergency situations. IV dextrose is a faster and better option in most cases. However, IV dextrose is like a 50 mil amp that you have to infuse, whereas glucagon you can give IM or sub-Q, and you can give it in, a patient could have this on them for an emergency. So it's more of like an emergency kit for outpatient use, but wouldn't really be applicable in a hospital setting. Ketoacidosis happens when there's metabolic acidosis with an anion gap. Blood glucose is highly elevated, but usually below 800. If somebody is totally comatose because of this, it might be much higher. And there's presence of ketone bodies. So this is a complication of not using insulin, and this could happen to somebody who's type 1 diabetic who's non-compliant with their insulin. Treatment for this, you would do fluid replacement, potassium, sodium bicarbonate, and then insulin. So usually we use relatively high doses. You give regular insulin because regular insulin is the only one that's approved to be given directly intravenously. So you put them on a continuous infusion of insulin and usually give them a bolus you monitor blood sugar and potassium frequently. As your biggest risk for doing this is to overdo it and drop their blood sugar substantially. Potassium also, we talked briefly about this last fall, but remember insulin drives potassium into the cells, and so you want to make sure that you're monitoring that as well and replacing that if you need to. The other thing that can happen with high blood sugar is something called hyperosmolar hyperglycemic state. This is more associated with type 2 diabetic patients. It's really high blood sugars with little or no keto acid accumulation. Treatment is, however, exactly the same. Basically, if somebody has high blood sugar, it doesn't really matter if they're HHS or DKA. I mean, you're still going to treat them essentially the same way with insulin IV. All right, moving on to type 2 diabetes. It's kind of my joke for the day. I always think of like a type 1 diabetics are kind of leaner overall and thinner. Type 2 diabetics usually got there by a little bit of overindulgence here and there in life. Obviously, I don't think Michael Phelps does not have diabetes, and I don't know if that guy does or not. I shouldn't judge, but who knows. So type 2 diabetes is very dangerous, especially when coupled with high blood pressure, smoking, sedentary lifestyle, and high fat, high cholesterol diets. The muscle basically just gets unable to use glucose because you get insulin resistance because you have so much sugar in the body that your body can't process it. Sugar. All sugar has risks. Keep active. Burn sugar. There you go. Increasing body weight increases risk of diabetes. In case you're curious about studies on this, impaired glucose intolerance is associated with diabetes and associated with percent of desirable weight. What desirable weight is, I'm not entirely sure, but that's what the study looked at. So type 2 diabetes is one of the most common adult chronic illnesses you'll encounter. I kind of think of it as one of those metabolic trifectas, right? You've got blood pressure, diabetes, and cholesterol. Those three things are going to be a core component of primary care management for the vast majority of patients, at least things you're going to constantly be screening for, if not treating for directly. So it affects about 8% of the U.S. population, probably heavily underdiagnosed. Out of all diabetic patients, 90% of them are going to be type 2, the other 10% obviously being type 1. Normal labs, you're looking at fasting blood sugar should be under 100, and an A1C should be 6.5% or less. Screening criteria for diabetes type 2, A1C over 6.5, fasting blood sugar over 126, 2-hour blood glucose over 200. Normal hemoglobin versus hemoglobin A1C. Remember, A1C is a measure of your hemoglobin's ability to transport glucose and how much glucose is bound to hemoglobin at any one time. The higher amount means that your body's kind of constantly got glucose. Your hemoglobin, constantly has glucose bound to it. Therefore, you have more glucose that you aren't using than you should have. There's a couple different guidelines out there for treating type 2 diabetes. There's two different major groups that publish guidelines in this area, and maybe even more than that, but these are the big two. There's ADA, of course, which is the American Diabetes Association, and then AACE, which is the endocrinologist group, and they have very similar goals, but slightly different, so I did want to point out what they recommend. So anyway, ADA recommends A1C less than 6.5. The goal for A1C for a healthy patient would be 6 to 6.5 for the endocrinologists group. I think that AAC actually stands for American Association of Clinical Endocrinologists, in case you care. Pregnant patients, there's a little bit different. ADA's goal is quite a bit different than the AACE goal, is much more strict. So you can see that across the board, usually ADA is a little bit looser than AACE, but it's very similar. Non-pharmacologic options. So certainly diet can have a pretty big impact on diabetic care, and I wouldn't doubt anyone who wants to try diet and exercise as a method. You just have to be really consistent and stick with it. And at a certain point, you might get too far down the pathway where you have excessive insulin resistance in your body, and you might be too far gone for diet and exercise, but it certainly should be a core component. So again, hooking your patients up with dietitians, even maybe physical therapy if you think that they have some restrictions or maybe have some injuries or things like that they might need to work through so that they can get back and moving. That's certainly important as well. So again, diet, calorie restrictions, food choices, and carb counting can all help people manage the amount of carbs they're intaking. Exercise will improve blood glucose utilization and insulin responsiveness. There's a small percentage of patients that can control type 2 with diabetes and exercise. However, studies out there that have looked at this have found actually that only about 3% of people achieve their blood glucose goals, and most people don't have compliance with exercise programs. Or if they are compliant in the short term, it doesn't last long term. So it's difficult to maintain this over time for the majority of patients. Now, again, there are going to be people out there that do this successfully, but there's going to be a majority of your patients that need some sort of assistance with this in the pharmacologic world. All right, so let's talk about the different drugs out there. Metformin is the core drug for any type 2 diabetic patient. You're going to give a drug that does the following things. It decreases hepatic glucose production, decreases intestinal absorption of glucose, and increases peripheral glucose uptake and utilization. Metformin is widely liked by pretty much everyone in the diabetes world because it has significantly good results. It can reduce A1C on its own by about 1.5%. So it's a first-line therapy for anyone with diabetes. There are a couple contraindications. Estimated GFR less than 30 is a newer recommendation with metformin. And it does maybe have some issues with kidney interference. And so people who are taking iodinated contrast media or surgical procedures, we hold it for them because they can have possible kidney damage with that. Otherwise, most patients will qualify for this. Of course, if they have severe kidney disease, we wouldn't give it to them. One of the reasons behind this is also something called lactic acidosis, which is associated with sepsis, dehydration, and hypoxemia. There's a lot of debate whether metformin causes this, but that's one of the reasons why people are a little cautious with metformin and renal function, is that it can cause this. But there's no real evidence that it actually has any impact overall. So it's sort of maybe a myth in medicine, but there is some older evidence that maybe points in that direction. I don't know. We'll see if that ever goes away or not. GI, diarrhea, nausea, vomiting, and flatulence, something that's going to maybe be 10 to 50% incidence. So I always recommend when you're starting metformin, just start them out on the extended release product. It's cheap and generic, just like the regular one. No reason not to, and it's going to be much better tolerated than the immediate release version. So this is really going to be your biggest impact as far as patient compliance goes, is the GI related side effects that some people just won't tolerate. The other thing I'll just point out about metformin is you might notice I didn't put any hypoglycemia as a side effect. Metformin has virtually no risk of hypoglycemia. And the reason why is if you look at its mechanism, it doesn't do anything with insulin. A lot of the other drugs we're going to talk about today increase insulin output or do something in the pancreas to modify the way insulin's being released. Anytime you're affecting insulin, you're increasing hypoglycemia risk. So this drug actually doesn't do anything with insulin, which is another reason why people like it so much. It just really is focusing on the glucose side of things. And it's very effective for that, and it also has virtually no risk of causing hypoglycemia. Now, on the other hand, sulfonylureas have a significant amount of hypoglycemia associated with them because they stimulate insulin release from the beta cells directly. They also have a couple other mechanisms. They're effective. They reduce A1C by 1 to 2%. However, they do show diminishing returns over time. These have been historic second-line therapies, or if you have patients with poor renal function, first-line therapy. Side effects include weight gain and increased beta cell failure potentially. So there's a whole school of thought out there with sulfonylureas or drugs that are forcing the beta cells to release insulin, that they will overtax the system that's already being strained. And ultimately, you can actually, while you can get short-term reductions in A1C, there's no debate with that. But what happens is you end up with a patient who is, over time, gets increases in beta cell failure. So historically, these were always added on to metformin, but nowadays we tend to, at least there's a fair amount of trend moving in the direction of not using these second line. These are the three drugs out there. They're the GLP or GLY or GLIM drugs. I don't know how you want to remember them. They start with G. Otherwise, there's a couple different dosing options. They're all pretty much the same as far as they work. Some have better, like for example, glipizide doesn't have any renal adjustment needed. So there's some advantages to using maybe that over some of the others, but otherwise there's not really any benefit or risk doing the other ones. The biggest thing, again, side effects is going to be the hypoglycemic risk, especially if people take these after exercise or if they miss a meal. High dose long-acting med or impaired renal function can also increase risk. Next category of oral meds, thiazolidinediones. Pioglitazone is a product called Actos, which was actually taken off the market in France and Germany because of bladder risks, and they basically said, there's a lot of other drugs out there to treat diabetes, we don't need this one on the market. There was another one in the US called rosiglitazone that was removed from the market due to perceived increased risk of myocardial infarction, and upon reviewing evidence in 2013, the FDA actually reversed their ruling on that, which probably made the drug companies super upset because they lost a huge market share because of that product going off the market. Mechanism, it's a PPAR gamma agonist that activates genes involving glucose and lipid metabolism. It improves target cell response to insulin, but does not increase insulin secretion. So another drug that doesn't really have any effect on causing hypoglycemia, so that's good. It does lower A1C a modest amount to a decent amount, depending. Patients are kind of variable in their response. Side effects are weight gain, fluid retention, and bone loss. So fluid retention is a big deal for heart failure patients, and so it'd be contraindicated usually to use this medication with those specific patients. DPP-4 inhibitors. Diabetes medications have tricky names. I just recommend spending some time with them to understand the different classes and how they all fit. So I take no credit for figuring out how these are all called, but this is how they're referred to. So instead of just calling these gliptins, which would be super easy, they're DPP-4 inhibitors. But they all end in gliptin. There's a few of them on the market. What these do is they prolong incretin hormone levels, which is dipeptidyl peptidase 4 enzyme inactivates incretin hormones, so it inhibits that enzyme, so you get more incretin around. Incretin regulates glucose homeostasis, which helps increase insulin secretion from the beta cells. So it's a roundabout way of increasing insulin secretion. Decreased glucagon secretion as well. A1C lowering is modest, but it's got some nice. These have some nice synergistic effects when added to metformin. They're fairly expensive, but they have a low hypoglycemic risk. They're well tolerated. The FDA has a warning regarding joint pain. There's like 33 cases over a 7-year period, which seems really low to me. Symptoms start 1 month after start, and then they resolve 1 month after stopping. So if somebody does get joint pain on one of these drugs, they should just stop taking it, try something different. There's also an FDA warning regarding heart failure, increase in hospitalizations regarding saxagliptin and alogliptin. And then there's some combination products out there. There's a new category of drugs, which we're going to talk about. And so there's a linagliptin empagliflozin combination approval tablet right now. All right, the SGLT2 inhibitors, sodium glucose cotransporters. These drugs are the gliflozins, as you can read here. These are probably one of the newest classes, maybe the newest class. Definitely the newest class of oral drugs out there. So what these drugs do is they reduce resorption of filtered glucose. So you just urinate out more sugar than you would otherwise. It actually can be substantial and result in a 200 to 300 calorie per day loss, which can over time cause weight reduction. This is one of the only drugs out there that has some proven data behind actually reducing weight that was actually sustained 2 years in current research. So there's some impressive data surrounding these drugs. These drugs are renally dosed. We don't recommend them if their GFR is less than 60. The reason is you have to have functioning kidneys for these even to work. And if your GFR is less than 30, they're contraindicated altogether. There is some data for canagliflozin only supporting maybe a reduced dose between 45 and 60 GFR mil per minute. Side effects with these are sort of all over the place. Hypoglycemia is mild, which is good. But you might have some hypotension, dehydration. Essentially, I think of these kind of as like a diuretic of sorts. They're going to cause some diuresis, so that can be something to watch out for. Because if you're preventing resorption of glucose, you're also going to present some resorption of free water in the same time. You increase serum creatinine, which can decrease GFR and can cause kidney injury in some cases. Increases in LDL. I have no idea why. And then these ones are kind of the interesting ones, the ID related. So if you think about you're excreting more sugar, what happens is that sugar maybe stays around in areas that have natural fungi or bacteria hanging out in them, and so you can get increased risks of UTIs. So especially in female patients, but also things like balanitis in men have been seen at significantly increased rates with these drugs too, just because of the increase in sugar that is in your urine, allowing a food source for those bugs that live kind of naturally. Increased risk in bone fracture, don't know why. Twofold risk of leg, foot amputation. Again, I don't know exactly why that is either, but so that makes it sound like these aren't the greatest drugs. But they have some decent, modest A1C lowering effects, and there's also a lot of studies with these looking at positive mortality benefits and CV outcomes. So specifically, these have approval, I think now, for heart failure use, regardless of diabetes, because they have positive mortality benefits. Now, you still have to make sure you meet the criteria with the GFR. So you might be thinking, like, where would you use these with all these odd side effects and, like, the modest lowering benefit? A lot of people like these actually for an early intervention for patients who are looking for weight loss and also for younger patients with healthy kidneys. So you would still probably start somebody on metformin, but this would be a good second option for those maybe healthier patients who can tolerate it with their kidney function, or especially if you had a heart failure patient who had diabetes. The GLP-1 agonist, glucagon-like peptide, there's a few different ones on the market. The short-acting ones aren't used very often anymore. Usually the long-acting ones are the preferred. You can see they're kind of similar. So there's exenatide, which is also an XR product, which they just extended the release of it by modifying it slightly. These are one of my favorite drugs from a natural source perspective. They found this compound exenatide by isolating some venom from the Gila monster, which is a lizard that lives in the southwest United States and Mexico, I think, too. All right, mechanism, increase glucose-dependent insulin secretion, decreases inappropriate glucagon secretion, and slows gastric emptying and decreases food intake. Sub-Q injections are really expensive. Compared to insulin, they're quite a bit more expensive, and some of them actually need reconstitution, which is super inconvenient. So, I don't know. Leave that up to you to determine whether that's worth it or not for your patients, but I'd probably stick to one that doesn't if I was going to prescribe these. But again, you might be heavily dictated by insurance on what they'll cover. They'll probably pick one of these and say, nope, you have to do Trulicity, otherwise you can't, prescribe it. And you're like, okay, I guess I'll pick Trulicity. Why not? It lowers A1C by 0.5 to 1%. Dosing schedules are variable. Some of them are dosed like once a week, some are once a day. It really depends on the product. There are some advantages. This is another product that's been showing some evidence for weight loss, which is another good thing for most of our type 2 diabetic patients. Low risk of hypoglycemia, And then liraglutide has had some early studies showing cardiovascular benefits. So again, this might be another class of drugs we might see being used for like heart failure, other cardiovascular indications. Side effects are GI related, nausea and vomiting, diarrhea, 10 to 50% of patients, renally eliminated, and they have seen thyroid tumors in animals which haven't been replicated in humans, so we don't really think that's a huge issue. Meglitinides are repaglinide and nataglinide. These are not super common medications. They're brand only. They're expensive. I'll let you read through them if you want. That's all I'm going to spend on them. I'm also not really going to talk about these drugs either because they cause a lot of GI side effects, and they're going to be like your last line option. Finally, insulin in type 2. Historically, insulin was reserved for failure or several oral agents, and then you would try to switch them to insulin. That's still kind of the case, but there is some more data to support aggressively using insulin earlier, depending on where the patient falls and how much, how high their A1C is at the time of diagnosis. So I'm going to show you a couple different treatment options now that we've talked about the drugs. This is a nice, easy approach. So if you look at the top part of this, basically you're looking at lifestyle and metformin for any diagnosis. Then, you could add on basal insulin or a sulfonylurea and then kind of move on to intensive insulin if that didn't work. That's sort of maybe a dated approach, but a basic approach to this. Now, if we look at maybe some newer approach to more complicated approaches to treating it, I think people struggle with diabetes because there's so many different options you can pick, and there's not really a right answer. You sort of have to base your approach on how appropriate the specific medication would be for that particular patient. But this is ADA's treatment guidelines. So basically, they're going to say, all right, your patient's going to counsel on healthy eating, weight loss, etc. Then they're going to start on metformin unless it's contraindicated. Okay. If the A1C is not achieved after 3 months, you're going to consider adding a second agent depending on patient-specific factors and drug characteristics. If your patient came in and their A1C was over 9, you would start them at this stage. So you'd start them on metformin plus one of these. Now, ADA hasn't taken a huge stance on which one of these is better than another. They basically say any of these are okay, again, depending on patient-specific factors. So let's say your patient's like, I am not injecting insulin. I will not inject anything. Okay, well, that rules that one out. Maybe your patient has heart failure, so that's going to rule out your thiazolidinediones, and that might rule in SGLT2. So there's some things to think about with that. But they're basically saying all these drugs lower A1C, and they all have different appropriate levels depending on the patient. So they might just say that they're kind of just taking a pass at it and saying, well, any one is really okay. You just have to tailor it to your patient. Okay, so then they say if your A1C isn't achieved after 3 months, you add a third agent onto there. And that's going to be one of these. So it depends on where you start. So again, all these include metformin. So let's say you went metformin, you're like, I'm going to add basal insulin next. Okay, so then you would just pick another one. It's really all just sort of a mix and match here. If the A1C is not achieved after 3 months and the patient is on one of these combinations, it tells you sort of what to do there and how to go forward. It does say here too, the A1C is greater than 10 to 12%, especially if symptomatic features are present. Basal insulin and mealtime insulin is preferred initial regimen. So they're saying if their A1C is that high, you want to just go straight to intensive insulin therapy. All right, and then the clinical endocrinologists have a little bit different of an algorithm, so I wanted to point this out too. So they have a little bit different entry guidelines, and so if your entry level A1C is less than 7.5, but again above that 6.5 threshold, your monotherapy is going to be metformin. Now what they're saying here is this is in order of how these people like their drugs. The endocrinologist clinical people do not like sulfonylureas. They put them at the very bottom. And they also don't recommend insulin early. Now, for dual therapy, they do put insulin in. These guys really like GLP-1s and SGLT2s. I think that's because of the dual benefit you're getting with cardiovascular benefits and weight loss. And also, they don't tax the insulin system. So I think the College of Endocrinologists are looking at all these drugs and saying anything that's going to, well, GLPs actually technically do kind of force insulin, but anyway, they don't do it quite as aggressively as maybe some of the other drugs. But what they think they're saying is let's try and avoid anything that's aggressively forcing the pancreas to do something, because we want to preserve what function we have. So they'll try other strategies. If your entry A1C is over 9%, you're looking at triple therapy, which is metformin, plus a second-line agent, GLP-1, SGLT2. If you have no symptoms, dual or triple therapy. Symptoms is going to be straight to insulin plus your other agents. All right, so again, the important thing to think about here is what each class of drug really does and where the benefits are. So focus on those little pearls of wisdom, like which ones have weight gain benefits, which ones have heart failure benefits, which ones are contraindicated in heart failure. Where do you start? You always start with metformin. Where you go from there really depends, and there's not a lot of right and wrong answers. And personally, I don't think giving a sulfonylurea to somebody is wrong second line, but maybe based on the body of evidence we're seeing, there could be a better option for that patient. Is that patient young and have relatively young with decent kidneys? Maybe the SGLT2s are great. SGLT2s are new and expensive though, so maybe their insurance won't pay for them. Those are all questions and things that you would have to maybe move down the algorithm. The insurance might not pay for a GLP-1 because those are expensive as well. So those are things that I don't think this algorithm really took into consideration as much, but I think they're saying if you have the option to do a GLP, that should be your second choice. That's what the clinical endocrinologists have determined based on the evidence that they have available to them. So again, how you interpret that is up to you, but the point is for this class and this exam is to look at the different agents and where their strengths and weaknesses are and where you might fit them into a particular patient scenario.